Welcome everyone to our webinar from the Australian Institute of Health Innovation at Macquarie University. My name is Chrissy Clay and I am the coordinator of these webinars that run throughout the year. Our topic today is understanding the impact of chronic disease and injury on academic performance based on a suite of research here at the Institute. Firstly, I'd like to acknowledge the traditional custodians of the land on which Macquarie University is situated, the Wallumattagal people of the Darug Nation, whose cultures and customs have nurtured and continue to nurture this land since the Dreamtime. We acknowledge the traditional custodians of the various lands on which you are joining today and the Aboriginal and Torres Strait Islander people participating in this webinar. We pay our respects to elders, past, present, and emerging. So most of you are probably already familiar with the Institute, but our goal is to create high impact health services and systems research that drives positive change in policy, practice, and behaviour for the benefit of all. We have 4 university research centres: the Centre for Healthcare Resilience and Implementation Science, which is led by Professor Jeffrey Braithwaite, who's also our founding director. Also the Centre for Health Systems and Safety Research, led by Professor Joanna Westbrook. The Centre for Health Informatics, led by Professor Enrico Coera, and the Centre for the Health Economy, run by Professor Henry Cutler. We also have 3 NHMRC funded research centres. So perhaps you've been thinking about doing a PhD, or you hear something today of interest. Think about joining our fantastic higher degree research program at Macquarie University. Jump online, check out our website, see our research streams, and if you'd like to know more, please get in contact with us. We often have scholarships available as well. So for our presentation today, understanding the impact of chronic disease and injury on academic performance, we'd love to hear your questions. So if you could put those in the Q&A as we go along, and then we'll get to as many of those as we can at the end. Also, just a reminder that this presentation is being recorded, just the presentations, not the audience, and that recording will be available on our very popular AIHI YouTube channel. You'll receive a link to that after the presentation, and please feel free to share that link with any colleagues. So without any further ado, I will now hand over to our chair for today, Emeritus Professor Les White.
Thank you, Chrissy. And good afternoon, everyone. It's a pleasure to be here, and thanks for having me. I too would like to acknowledge the traditional owners of the various lands where we find ourselves. I'm on Gadigal land in the heart of Sydney. I do have a long history with the Institute, but more to the point, I have about half a century experience in children's healthcare, which makes me keenly aware of the importance of the topic for today and also of the work of the 2 speakers. Chronic disease and injury in children and young people has become an increasing reality and challenge in Australia and globally. One of the drivers is the paradox that while we have had enormous progress in scientific discovery and improvement in clinical care that has saved lives, many lives, all the way from newborn care right throughout childhood, it has rarely led to a quick cure. So a common, or I want to say most frequent consequence is that children and young people are living with a chronic condition, albeit often manageable. There are many consequences of living with a chronic condition in childhood and adolescence, but none more critical than the impact on schooling and education. Of the approximately 1 million children in Australia who have a chronic condition, about 100,000 each year will spend time away from school. We know the importance of schooling for a child's well-being, development, socialization, as well as education. Now, let me say a few words about the speakers. First speaker is Associate Professor Rebecca Mitchell, who heads the Health and Societal Outcomes Research Stream at the Institute. That's the Australian Institute of Health Innovation. Rebecca is a psychologist and injury epidemiologist by background, and it is in fact through Rebecca's work in epidemiology of injury that we first met many years ago. She has continued her great work with large-scale epidemiological and mixed method research projects that are of critical relevance to healthcare policy, delivery, and outcomes. Now, let me say a few words about our second speaker, Barbara Ryan. Barbara is a long-serving CEO of Ronald McDonald House Charities Australia. I'll abbreviate that to RMHC. Among a number of responsibilities as CEO in a large national federated children's charity, she oversees the development and implementation of a range of programs. I've also had the pleasure and privilege of working with Barbara over many years as a national board member of the charity and on various subcommittees. Before her current role, Barbara has served in the health sector as a physio and administrator, so both in policy and at the coalface. In the not-for-profit sector, she has held previous positions with the Royal Flying Doctor Service and as CEO of a division of general practice. The work undertaken by RMHC in seeking to address the schooling challenges that we talked about with children with chronic illness is exemplary and effective. The Ronald McDonald Learning Program is a flagship of the charity and is making a difference throughout the country. RMHC also has a robust evaluation and research policy and is keen to receive your full feedback today. Thank you for that opportunity to introduce the speakers. I will now hand over to Rebecca.
Thanks, Les. Okay, so today I'm just going to talk a little bit about one of the studies that we have conducted where we looked at further understanding the impact of chronic disease and injury on academic performance. I too would like to acknowledge the traditional custodians on the land of which we're all gathered around today, that has previously been acknowledged by both Chrissy and Les. So in terms of the research, a lot of my research has looked at health outcomes after injury, and whether that be a work-related injury or a road crash or a injury after falling from a piece of playground equipment, for example. And the health outcomes that we generally look at are time to recovery or the impact on health and well-being of the person that's been injured. But I guess this was now an attempt to try and extend some of our learnings around outcomes after injury. And so we wanted to have a look at what potentially might be some of the social impacts following injury, particularly serious injury. And would an injury have any sort of adverse impact on a child's performance at school, their academic performance? And then we thought, well, what about, we're going to have a look at injury and its effect on school performance, but what about other common chronic childhood diseases in Australia? And the four of the most chronic asthma, mental health, epilepsy, and type 1 diabetes. So we decided to have a look at those four chronic conditions as well as injury and the effect on school performance. So to start off with, we had a little bit of a check about what the literature says. So it's generally well known that injury and those 4 chronic conditions can have quite a serious and long-lasting impact on a young person's health and well-being, particularly if they're not adequately controlled. And there is some research that shows that academic performance can be affected, particularly a child's ability to learn and concentrate in school. That can really be interrupted. Which over time can have a cumulative effect that can result in a young person even not completing high school, not going on to university or TAFE studies, which can then affect their later employment opportunities. So we delved down a bit further to see if there was any evidence of impact on learning in the literature. And in relation to injury, a lot of the research had been conducted around traumatic brain injury and children who'd received that type of serious injury, and shown that they did have some problems learning new skills, and some young people had a loss of confidence. But in the existing literature, a lot of the comparison groups were also other injured children. So, for example, a young child with a traumatic brain injury might be, their academic performance might be compared with a young child who'd had an orthopedic injury, so a fractured femur, for example. So there's been no real comparison of a young person who hadn't been hospitalised for an injury. In terms of asthma, there was a bit of inconclusive evidence. There is some research that does suggest that there can be potential cognitive deficits. There was strong research for epilepsy showing that seizures can particularly affect difficulty with attention and concentration and result in memory loss. For type 1 diabetes, there was evidence of particular effects on cognitive and attention and memory loss. And for mental illness, there was evidence of deficits in engagement with learning, and particularly around motivation to learn for young people. So in terms of the number of people that we were that have these injury or chronic conditions in Australia, there's around 70,000 young people who are hospitalised annually for an injury. 658,000 young people estimated to be living with a mental illness, just under 500,000 with asthma, almost 24,000 with epilepsy, and 6,500 with type 1 diabetes. But that although our study that I'm going to talk about in a minute focuses on young people who've been hospitalised, just good to know that not all young people with each chronic disease or with an injury were hospitalised. So in terms of our study, what we aimed to do was to compare academic performance of young people who'd been hospitalised with an injury, or those 4 chronic diseases, to other young people who had not been hospitalised for that particular condition. So essentially, we were running 5 matched case comparison retrospective cohorts in New South Wales. We included all young people aged 18 years of age or less over a 13-year period. And we selected the comparison cohort from using birth records, and the comparison population was randomly selected, but they were matched to be the same age, the same sex, and to live in the same residential location as the young person who had been hospitalised. Now, we did need to access a lot of data, a lot of information for this study. So as I've mentioned, we used the birth records to identify the comparison population. But for both the injured young people, or the people with the chronic disease, and the comparison group, we had information on all their emergency department visits, all their hospital admissions. We had to link to mortality information to exclude young people who had died from our study. For the young people who had mental health issues, we had their outpatient mental health client contacts as well. And we had, as a measure of an objective measure of school performance, we linked to our NAPLAN, so the National Assessment Program of Literacy and Numeracy in Australia, that's conducted in grades 3, 5, 7 and 9 throughout all schools. For this study, we also did link to high school completions, but just for time today, I'm not going to show those results. So for the statistically minded, we conducted a generalized linear mixed modelling, but for everyone else, what we're just to focus on, we are looking at examining the risk of academic performance below the national minimum standard on the NAPLAN results. And I'm just going to focus in on reading and numeracy from the NAPLAN compared to matched peers. We had a number of factors that we could control for in the information that we had available. And we controlled for obviously the health condition, age group, sex, other different comorbidities, hospital length of stay, highest level of education and occupation of the parent or guardian, language background, residential location, socioeconomic status, school grade and school sector. So the school sector was divided into government, independent and Catholic schools, and the majority of young people did attend government schools. So in terms of our results, what did we find? So these are showing relative risks, and what you're looking for is anything above 1, anything that doesn't cross that line in the middle is showing a increased risk of not achieving the national minimum performance. So these are the results for injury, looking at numeracy and reading. And you can see for injury, young people who are hospitalised with an injury had an increased risk of not achieving the national minimum standard compared to their peers. And that risk increased as the injury severity increased, except for moderate injury for numeracy. When we look at the results by chronic disease, and here there were some differences by males and females. So I've split the two graphs into males and females, and both graphs looked at reading and numeracy. And I guess here the key information is around epilepsy. So for both males and females, young people with epilepsy had between 3 and 4 times high risk of not meeting the national minimum standard for both reading and numeracy. And for males with asthma, they also had a high risk of not achieving the national minimum standard compared to their peers. Looking at mental illness, again, there were some differences by males and females, and we also differences by type of mental illness. So these are just showing the results for males and females just for numeracy. And I guess the key information is the first row of any mental illness, and it's showing that both males and females had an increased risk, about 1.5 times higher risk of not achieving the national minimum standard for numeracy. Also, anxiety disorders, conduct disorders, and for females, depression also had a high risk, particularly of not achieving the national minimum standard. For substance disorders and psychotic disorders, but particularly for females, there were some wide confidence intervals, and that's due to small sample sizes. And just looking at the results for males and females for reading, again, similar for males, not for females. So for males, they had I think it's about 1.7 risk of high risk of not achieving the national minimum standard compared to their peers. So we did have a few study limitations. We only included hospitalised cases. We had no information on the severity of the symptoms for chronic diseases. We couldn't take into account school absences with the information we had, and we didn't have any information on specialist tutoring. Now, the good news is there are some services available for learning and support for young people, particularly those that we found who had a high risk of not achieving the national minimum standard. So for males, with asthma, mental illness, injury, and young people with epilepsy. So here, I'm just put a few slides up of some of the resources that are available. So there's for asthma, looking at targeting educators in schools. And there is Epilepsy Action Australia has their Strong Foundations program, which looks at focusing on parents and caregivers. And we're just about to hear about another fantastic program run by Ronald McDonald House with their learning program. In terms of prevention as well of the disease, there are some activities that could also be focused on around successful seizure control for young people living with epilepsy, and care coordination between primary, acute and other care settings. For asthma, I guess for males where they weren't achieving as well, a better management of their symptoms and following the asthma management plan. For type 1 diabetes, we didn't see any negative effects at all. And we're thinking it could be around already improved glucose control and management. And for mental illness, also care coordination and symptom management. Just a couple of implications for policy and practice. Symptom management and integration of care, very important. Very important to recognise the need for learning support for some of the young people who have sustained an injury or a chronic condition and been hospitalised. Need to start thinking about return to school protocols for these young people, and also around their ongoing need for learning support requirements over time, and of course to monitor their progress. And I just have a few acknowledgements for everyone who has been involved in these studies, and to also the government departments who provided the data for us for linkage. Now I'll just stop sharing my screen. Just a reminder, any questions in the Q&A, and then I'll hand over now to Barbara, who's going to talk about the Ronald McDonald Learning Program and other activities.
Thanks so much, Rebecca. I'll just bring up my, my slides now. Thanks so much. And just a reminder, as Rebecca said, to put any questions in the chat function, and they've left. Chrissy's done a great job of leaving time at the end if you've got any questions that you want answered out of this session. So thanks again, Chrissy and Rebecca, for inviting me to speak today about what we believe is a great program, our Ronald McDonald Learning Program. Firstly, I'd like to just acknowledge again the traditional custodians of the lands on which I'm coming to this meeting to you from, and pay my respects to their elders, both past, present and emerging. First, I just want to give a bit of a snapshot about Ronald McDonald House Charities and just the range of services and programs that we run across the country. And I'll just capture them really quickly in a couple of slides. But firstly, our Ronald McDonald House program, and many of you will know that. We've got a learning program, a family room program. We've got our Ronald McDonald Family Retreats, our hospitality card, and of course, what I'm talking to you about today, which is our learning program. With our Ronald McDonald houses, we've got 18 Ronald McDonald houses across the country, ranging in size, but you can see there our North Fitzroy house, which has 25 rooms. So every single night we care and support for about 489 families every single night. And at the moment, last year, we saw more than 9,500 families actually come through the doors of a Ronald McDonald house. What happens at a Ronald McDonald house, and you see there, that's Westmead, which is a 60-room Ronald McDonald house. It's so that families can stay together, but as close as possible to the medical care that their seriously ill or injured child needs, right next to the hospital, so that they are just literally footsteps away from their child when they need that care. We also have Ronald McDonald family rooms. Now, these are spaces inside a hospital, and they enable families to be able to get a bit of a respite and a time away from the bedside, be able to go to a space which is hopefully less clinical-like, and you get an example of those in front of you now, where they can, I suppose, rejuvenate, you know, just get their energy levels back, make a cup of tea, have a meal, put their washing on, connect with their partner or their other children, allow their other children to run around before they go back to the bedside. So these are great spaces across the country. And we've got 20 Ronald McDonald Family Rooms in clinical locations across the country. Our Ronald McDonald Family Retreats, this is an opportunity for families really to reconnect after they've been through that terrible phase of having a seriously ill child, and they've had psychological pressures, emotional pressures, financial pressures, where that family can get away and actually have a holiday together, where many of those families wouldn't have the opportunity to do that in this very, very busy time. So that's an opportunity for them to focus on not just their seriously ill child, but as we know, some of the real issues are with siblings who are as impacted as the seriously ill child themselves. So that family can really get a chance to rest and recharge and reconnect and get themselves back together and be resilient as a family. And there you can see there our Ronald McDonald Family Retreat, which is at Bateman's Bay on a private beach. So they're beautiful places. We've also got a hospitality cart, and we've got more of these in the pipeline. So that really brings the support and care to the families at the bedside. So in places like Mount Isa Hospital, where really you can't drink the water, we provide water, we provide care packs to the parents at the bedside. We've got games and snacks for the children if that's appropriate. So that's an opportunity where we're able to support those families that are in hospital with a seriously ill or injured child. But what I'm here today to talk to you about is our Ronald McDonald Learning Program. And that, as Rebecca's already said, is there to support children that have had a seriously ill or illness or injury or a chronic illness, and we'll talk a little bit more about this later. And we provide a tutoring program for these children so that they can catch up on many missed education. And this is available to children from kindergarten all the way through to year 12. We provide this service, and as it says there, we provide it both face-to-face and also virtually to these children. During COVID, or within 2 weeks of COVID really coming into our world in 2020, we converted our face-to-face tutoring program to a virtual offering, and now we're able to support children with both opportunities where parents can choose to do a face-to-face tutoring or they can do virtual tutoring. It also means that maybe some of our students and vulnerable children aren't waiting for a tutor in their local location, but we're able to connect them with potentially a tutor in another location. And that's particularly relevant for children and students in the higher level of education in maybe years 10, 11 and 12, where they might be after a specific subject tutor, and we can link them with that specific tutor in another location. We might have someone, a child in Brewarrina in rural New South Wales who wants a physics tutor, and we can connect them with a physics tutor in Adelaide, and they don't have to wait for someone locally that they need to connect with. So I want to go through the learning program in its totality, and we've got a whole package of support for these children. One is the, as I said, the tailored tutoring program, and we'll talk about that in a minute. We've also got a program which we talk about with our EdMed program, and that's where we have the opportunity of having an accredited program where we delivered to teachers in school about how to deal with children when they come back into the classroom after they've been away from the classroom because of a serious illness or injury or a chronic illness. How do they deal with these children when if they've got cystic fibrosis and they've been up exceptionally early in the morning to be treated, and then they come to school but they're falling asleep later in the afternoon? How do those teachers manage that? What we have got is we've been able to deliver this face-to-face across the country to more than 30,000 teachers or even undergraduates. We're connecting with a couple of universities where we are delivering this program to teachers in training really to be able to deliver this level of education and how to deal with a range of different illnesses and when they come back into the classroom and how they deal with these children. As you can imagine, with these teachers, they're dealing with one too many, and these children coming back in the classrooms are just one of these many different issues that teacher has to deal with. We do this program either face-to-face in the school, so we can send people out to the school and deliver this program, but it's also available online, and we've had teachers around the globe accessing this opportunity online, which is fantastic. And often it's a way for us to help these students and children if we're unable to do the tutoring program very quickly. If we can't get a tutor quite quickly, we can deliver this program. So hopefully the school environment and the teachers are aware of some of the issues that these children might be facing as they come back into the classroom. As you can see pictured on screen there, there's also this What About Schools booklet that we've developed. As you can see there, it was quite a consortium across the tertiary paediatric hospitals and facilities across Newcastle and Sydney. We worked with them, and this is for particularly children that have got a cancer diagnosis, and it's something that it's a resource booklet that we give, or that's given to parents so that they can look at what type of diagnosis or grouping, clinical grouping that child has been allocated into, and what that might mean for that child moving forward about their schooling, what they could think about. So it's a resource for them to pick up at any time and look at what should they consider, what sort of things could they talk to their teacher or their school environment about when they come back to school, and what's relevant to a primary school student all the way through to a senior higher level student, what they could be thinking about, what they could have in play, what they should be talking to their schools and teachers about now or through that child's clinical journey, which I think is really, really important. So it's a great resource tool that's available that we've done in collaboration with these clinicians. And when I go back just for a minute with the EdMed, we cover off quite a range of clinical diagnoses in that program, and there's a resource book that we leave with every teacher that we deliver this to, so that they can take that away and refresh and learn. And we develop those with our clinical experts. It's not us delivering that. We do the education side and how we can help from that side, but developing the clinical knowledge is very much done with our clinical partners or relevant associations. We also deliver every second year an international, what we call HELP conference. So that's Health Educators, Learners and Parents Conference. And the idea of this conference was to bring together those two industry sectors. So to bring together the health practitioners and the education practitioners in one environment so that they can have these dialogue and conversations about how best we as a society, as a industry or industries, if we get together, support these vulnerable children that often are falling through the cracks between the health system and the education system, and who is there to help pick up these children. So we have industry experts come and talk. It's a forum for best practice sharing. It's a hotbed of ideas, as you could imagine with any conference, and we often get countries coming to sit in and be part of our conference, but we also get international speakers come and speak at these conferences as well, which hopefully has made a little dent in helping these children with what they need to face as they go back into the schooling environment and pick up their education after such a gap, as Rebecca's already said. One thing we are looking at moving forward is, as I mentioned with our learning program, currently we're focused on school-age children. We're ranging from kindergarten all the way through to the final years of school. What we're looking at now is what happens to those preschoolers. So we're calling this trial program Making Milestones. So we're investigating and trialling some programs about how we help these children that maybe have their developmental milestones have been impacted by having a chronic or serious illness in those very important preschool years, and how can we help in these children hitting school and making sure that they've got everything that they need set up and in place. So with our learning program, what I wanted to talk about the tuition side of our learning program, what I wanted to talk about was the eligibility of our learning program. And this is just some of it, but we generally having the great opportunity of being a charity, we're able to be a bit flexible, and we deal every child on their case-by-case basis, and we look at the needs of that child. But the primary focus in relation to children coming onto our learning program is that they have had a serious illness or injury or a mental health condition resulting in some form of hospitalisation and is under medical care. So it is, and it can be a chronic illness, but something that has interrupted their schooling. And that's the next point, that they've had a reasonable time off school. We generally use a term that has impacted their learning. Now, this doesn't have to be a consecutive period. It doesn't have to be a singular period of a term of school. It can be cumulative. So if the child has been diagnosed, for example, with epilepsy, and because of trying to manage their medications and getting that on track for that child. As we know, this could be that that child's off school for 2 weeks and then they're back at school for 3, but then they might be off for another 2 weeks and then back at school for 1 and then off school for another week, etc. So if we believe that the time away from school is impacting on their learning, then we step in and make sure that it's something that we can offer that child. The student is obviously well enough to benefit from the educational support and is attending school regularly. So the idea of this program is not when they're in hospital, it's when they've finished hospitalisation and they're transitioning back into the classroom that we can then step in and supplement that classroom learning. And part of this, the tutors that we employ to deliver this really link with the classroom teacher and their child's residential school to make sure that it is whatever plan we develop, educational plan that we develop for this child, absolutely sinks in with what that classroom and that teacher already has identified for that child. But they must be attending school regularly, and that they're well enough. However, again, taking everything on a case-by-case basis, we are also flexible. So if a child starts the learning program and for unfortunate reasons, their medical condition, they may relapse, we're able to put it on pause, or we're maybe to say to that tutor for the next 2 weeks, let's just pause this and then pick it up when that child is ready to pick up that tutoring. So we're able to be flexible and manage that. The needs of the child is obviously paramount for us, and we put that as our primary focus. So when we look at some of the elements in our tutoring program, particularly with children in the primary school years, but it's available to any child, we have a educational psychometric assessment, just so that we're completely cognizant of what that child's needs are. And that feeds into the second point. For example, if the child's in lower primary education years, we might say that to supplement the tutoring support that we're able to give this child, we may then be able to offer occupational or speech therapy so that they can focus on things like fine motor skills or other attributes that's going to impact on their learning and their educational outcomes. So we do the assessment first, we understand so that appropriate student learning program plan can be put in place. And if we need to bring other experts in, such as occupational and speech, but it doesn't have to be those, then we will pay for and have it part of our Ronald McDonald Learning Program for these children. As I said, the tuition is often face-to-face to these children. Now that can be, and so we always make sure that that's in some form of public place. So what we do is we recruit a tutor that's relevant to that child. If it's a child in the primary school years or as I mentioned before, child in a secondary school or even in higher education, we have a really great open dialogue with the parents, with the child if it's relevant, with the residential school and that child's classroom teacher to say, for example, if a child's in year 12, we really work hard on being flexible and saying, what is the needs of this child? And they might say that they want to focus on maths. You know, they're lagging in other areas, but that's their focus. So we'll make sure that we get the most appropriate tutor for that child. We can even, we often say we offer it every week. We offer up to 40 weeks tuition for these children, which is basically a school year. So it's 1 year free tuition for these children. We might be able to condense that. We might be able to, you know, work with whatever the needs for that child so that they can, for example, a child in year 12, then will be able to sit the relevant exams for that child and then graduate with their cohort. So we're very flexible. But as I mentioned before, we also have an offering of a virtual tuition, and that can be, we've got all the rules and regulations set up and how that can work to make sure that that child is safe, but is still receiving that tuition how and when they need it. As I mentioned, we have a very strong liaison with the child's classroom teacher and residential school, so that therefore the child's needs are very much met, and we're working in collaboration with that classroom teacher. The tutor also works very closely with transitioning the child off the program, so they often are an advocate for that child into that school environment. We know from parents that not only have they then had to deal with as we know, the monolith of the health system and knowing how to navigate that, once their child has gone through that environment and that the treatment and the clinical process, they then faced with the education system and how do they advocate for their child. What we then say is, we can help you, and that tutor will be able to do that for you so that they can advocate for that child into the school environment, whatever that child needs to make sure that their educational needs are met. And of course, we have the necessary student learning plan for every child. What we have done is we've been able to look at what this means, what the actual outcome is. And when we look at our social return on investment, what we've been able to say is for our learning program, for every dollar invested, we've got a return of $4.50 to help improve the lives and the educational outcome for these children on the learning program. We know that we see approximately 1,100 children every single week on the learning program. So that's averaged out obviously over the year, but you can see there the impact that the parents believe when they have a child that's on the learning program about building their self-confidence and also benefiting their educational outcomes. And we know that if you have a more confident child, if they're feeling better in themselves, that they are more receptive to learning. And we find that when a child has been out of the educational environment for some time, they will start to have words in their head, as we all know, that they don't think that they're worthy, they're good enough, potentially they're dumb. So enabling that child to have the self-confidence that they need to be able to walk into that classroom and put their hand up, I think is really important. We also know that this actually benefits the actual public system. And so we know that it's creating a huge benefit. We know out of that 1,100 cohort, we save about 45 children every single year from repeating a year of school. And we know that we save about 49 children from actually dropping out of school altogether. And that's the quantitative benefit to the education system. But I think the benefit to those children and keeping them on their life trajectory is the absolute benefit that we're all looking forward to. Look, you don't have to read this, but this just talks to why, from a parent's perspective, why they believe the learning program is such a benefit to their children. As I said, not just the educational outcomes, but the social and psychological outcomes for their children is such a benefit to them. So I think the reason why I think it's so important to link with, oops, I've gone one slide too many, with people like Rebecca and the fantastic work from that study that she's already talked to, is that helps inform us as to how better meet the needs of these vulnerable students. What do we need to do? Are there things that we need to look at? Explore new programs, as I've already said, in the making milestones, and also help us build a business case of support. Currently, we get no funding for the learning program across the country, which costs us in the upper realms of $5.6 million a year to run our learning program. So it helps us put a case of support to philanthropists, to government, anyone that will help us support these children moving forward. So thank you for the opportunity to share what we believe is a wonderful program, and hopefully you've learned a little bit about Ronald McDonald House Charities. Thank you. I'm going to hand back to Les.
Thank you, Barbara, and thank you, Rebecca, for those excellent presentations on what I already have expressed as such an important topic. It does give me a sense of what we would view as comprehensive care of children and young people, to incorporate their whole lives, not just the specifics of illness. It occurs to me that the impact of chronic illness and injury is so complex and has so many factors, but one of those factors is missing school. And even that is both qualitative and quantitative. So while we are conscious of quantitative, where the child actually doesn't turn up, there are lots of obstacles to learning, even if the child is at school, in terms of engagement and participation. So it was good to see the Ronald McDonald Learning Program deal with those aspects, both directly with the child and through the providers or teachers in assisting their capacity and knowledge base. And that, to me, is a good dual approach. Looking at Rebecca's data, hospitalization is a useful surrogate for what we are trying to get a grasp of, the total impact of chronic illness on children and young people. And paradoxically, may I say, the healthcare setting may also be a place to try and address some of these challenges. And I do at this point acknowledge several comments in the chat from Caleb Jones, who has a lot of wisdom around educational aspects. And the healthcare setting can be a useful place to address gaps, both through the healthcare professionals, through other inputs like Ronald McDonald Learning Program, and of course the hospital school, which a lot of larger facilities have, but not all facilities. So there may be, I do have a few questions as well, and I'm just trying to say there's a few coming up. Maybe I'll hold it for them for a minute and let the Q&A take over. But if I do have a few questions to both Rebecca and Barbara as time goes by. So Rebecca, maybe you can handle some of the chat, the Q&A.
Yes. So just looking at the Q&A that we have a question from Caleb Jones. Having completed some research in Western Australia using hospital school data, we found controlling variables when each young person's circumstance is so different resulted in very small cohorts. Do you have any comments on how to compare impact of interventions provided, such as hospital school, Ronald McDonald House, where a control group who have not had supports is difficult to source? I was just having a bit of a think in the gap about what potential comparison group that you might be able to have a look at. I guess I've got a few ideas. Initially, maybe conducting a pre and post study, so before and after the intervention might be a possibility. Advertising for comparison group for young people who have the condition of interest. I'm wondering if you could potentially tap into existing cohort studies, such as the Australian longitudinal study of Australian children. Potentially, I know they do link to NAPLAN, and you would be able to identify children who had particular health conditions. Or the other my other idea was non-hospitalized, like such as similar to what we used. A couple of examples there. Have another question from an anonymous attendee. I think it's a big equity issue. Unless a child has access to the NDIS, there are no financial supports for many children with chronic diseases. And the result is that families who have the means can access additional external school support, such as tutoring, and those who don't miss out. And I think that's very true. And it's a bit unfortunate in the data sets that I had available, we weren't able to identify whether a young child had received NDIS for the services. Barbara, do you have any experience on that side?
Well, I think the issue for us is, as long as our criteria is met, we will accept any child. So if they've got a chronic illness, I think and as I said, I think which is really important is we take a child on a case-by-case basis. So we are extremely flexible. I think if a child doesn't have NDIS and they are having significant time off school, then they are eligible to come on the learning program. And I'm happy for someone to reach out to me and talk about that and how we can promote that more. I think it's we are here for children that have got an illness or injury that literally is falling behind in their education because of their time away from school. So as long as we've got all those things covered, I think that those children would be able to access the Ronald McDonald Learning Program.
Yep.
So just to emphasize Barbara's comment that the whole point is that it's an equity factor. It's not finance dependent. This is, once you're eligible, there's no cost. So
correct.
The thing is that addresses the important question raised. Maybe I can just put a quick question for both of you in terms of, because Rebecca mentioned the capacity to analyze. Is there any prospect, or is it feasible at some point to do a sub-analysis using same methodology of children and young people who've been through a learning program or an intervention to see if it has an impact?
I mean, that would be a fantastic idea, but at the stage we didn't have that information available. So I think we'd have to, I guess, maybe do another study and also something more recent, and make sure we had a data collection or some information about what children had received a program. I mean, that would be fantastic.
Yeah, that's what I thought. I thought about it, the next version.
The next phase.
Yes, and to do it in a more focused way. But as I fully acknowledge, there are enormous challenges in that.
Yeah, the other piece of information that would be great to have is when children, and how many days children had absent from school. So that would be my 2 extra pieces of information I'd love to have. Right,
agreed. So I'll hand back to you because I'll save another couple of questions for later.
Okay. So I have some questions also from Caleb Jones around hospital schools, and I'll try and combine them. So interest in different support organisations, but I in particular didn't mention hospital schools, and they do operate differently across the states. Just for me, I had to cut out a few slides from my normal presentation to get it down to 20 minutes. So that's why I'm missing a few things that I would normally acknowledge around hospital schools and diabetes programs and things like that. So it was just a timing issue.
Rebecca, can I just say also to Caleb's point, and he's mentioned it a few times, so thank you so much for reminding me. Hospital schools and Ronald McDonald Learning Program work literally hand in hand. So we work very closely with them, and once the child leaves there, we pick them up and continue, and it works across the country. So they are huge partners of ours, and we work very closely with the hospital schools in all states and territories.
Thanks, Barbara. The anonymous attendee, there is a gap between health and education. Who is responsible, looks after the education needs of children with chronic conditions. There's also a gap between children with chronic illnesses for a finite period, such as cancer, and those with lifelong chronic illnesses. schools do not often receive funding for extra teaching resources for children with a serious and continuing illnesses. And the Ronald McDonald House program is great, but the threshold for which children qualify for this and similar programs is high, and many children in need miss out. I guess I'd probably say there are some programs available online and other support services available online, particularly if, I was going to say if it's not a kind of a severe chronic illness, but particularly if it's kind of an intermittent chronic illness, although that probably doesn't really help a lot in terms of ongoing support. But
so I'd love to know from my perspective where the threshold is too high, and there's always got to be a threshold because there is always a dollar component. But you know, as a charity, we'd love to know what children, where's that subset of children that aren't making this. Now, I'm not necessarily saying we'll do the tutoring program, but we always explore, or we've got the ability to be able to look at many ways to help these children, as you saw by our comprehensive package of support. When we talk about, you know, how can we educate the teachers, the help conference that we have. So I'd love to know who anonymous attendee is and talk to them about what is that, where is that threshold, what are those children that are missing out, what's our program threshold that seems to be too high, and what other ways could we support these children. So it would be great to have that dialogue. We're open for anything.
That was one of the hoped benefits of this interaction, is to set up those offline conversations. But I also note in that question there was a mention of the education system itself, and it's fair to say that most state education systems have got an awareness and some level of officialdom interested in this question, and there are some challenges in progressing that, but it's something that we need to progress, to engage education formally and identify the players who are responsible for dealing with children who have been disadvantaged by healthcare issues. So that's something that needs to be pursued with education departments.
I might also mention that myself and another colleague from the School of Education at Macquarie University have both presented our research findings to the Commonwealth Department of Education and Training. So they are aware of the research and the results, and they were particularly interested in the results around children who were experiencing mental illness.
So it looks like my opportunity to ask further questions will be limited by time, which is fine because I can ask them anytime. Is there time for any more quick ones from the Q&A?
You've got 1 minute.
There's a couple there, yeah. While you're looking, maybe I'll ask a quick one.
Yep.
I noticed some interesting findings around injury where mild and severe were significant and moderate wasn't. And I can think of hypotheses around that. But did you find anything that surprised you? Were there things that you didn't expect to find?
I was surprised that we found an effect at all with injury. I was thinking that it wouldn't be significant, the results wouldn't be significant, but it just shows even a minor injury over time can end up having an impact. And I have to say, like, I've conducted lots of research, but publishing the first study, when we looked at injury and school performance, I had so many members of the public contact me and say, yes, that's been my experience myself, or that was my experience for my child, than any other piece of research that I've done. So for me, I thought, well, it's hitting home, and it's this type of research is filling a need, even if it just confirms what people anecdotally have been saying for a while.
And may I say, and I less than a minute, that the fact that you've documented these findings is very helpful in meeting with government agencies or even encouraging Barbara's program. You need the data, the evidence, then you've got that documentation that the need is there. The next question is to hope to document some implementation of the interventions. But I think both of you have provided great work, firstly documenting it, and Barbara in the programs that seek to address what is now a well-recognized problem. So I think that's time for me to close. Chrissy, is there anything else?
No, thanks everyone.
Thank you everyone for your participation. It's been very informative.
Thanks, everyone.
Thank you.